Well, it is such a pleasure to be here and welcome you all to San Diego. I'm Rachel Ford Hutman, and I was chosen to moderate this panel because I'm really just a patient. I'm completely neutral on this topic. I have a background in healthcare communications, but I'm really here to learn from all of you and help navigate this divide. So we've heard a lot about the barriers around access to healthcare, and according to a poll from the AP, only 12% of Americans are currently happy with the US healthcare system. So we clearly have some work to do. So we're going to dive into this topic and hopefully all learn more and potentially bridge this supposed divide that we have. So to kick things off, if you could all please introduce yourself and then just briefly tell us about you and your clinic model. And maybe we can start at the end.
Am I just going to yell real loud?
No, you're sharing 2 microphones.
Oh,
there should be one more. You guys are going to have to share, so.
And
that's how we're going to bridge this divide. Ms. Caring.
Right, they cut us off. So my name is Monica. I'm a family nurse practitioner. I own Impact Family Wellness. I opened it 4 years ago with myself, trying to give myself a job, and now I have 2 locations. I have a total of 5 nurse practitioners, and we have about 1,300 patients, and we're located in the suburbs of the north side of Austin, Texas.
I'm Ryan Neuhofel. I'm a family physician in Lawrence, Kansas. I opened a DPC practice in 2011, which I think is 12 years ago now. And I was the first president of the DPC Alliance. And I'm happy to be here and talk about this.
Thank you. If they have one over.
My name is Vance Lassey. I opened my practice in rural northeast Kansas in Holton in 2016, so I guess 7, 8 years ago. We are a pretty broad spectrum family medicine clinic. We also did OB until our hospital shut down OB services, do inpatient as well, fairly large degree of surgical stuff. And then we have a second location now as well. And it's just me, and in my office I have a nurse practitioner, 2 nurse practitioners in my office with me, and then I have another one and a PA at our second office where I'm still trying to recruit for additional help.
My name is John Rothwell. I'm from Merritt Island, Florida, near Cocoa Beach in the Space Center. And so I opened 4 years ago. We have about 600 patients there. We're getting ready to open up our second office because we're 70 miles long, our county. And I was the first DPC there and mentored 3 other practitioners, physicians and a nurse practitioner. And so now there's 4 DPCs in Brevard County, so we're happy about that.
Wonderful, wonderful. Well, first off, as a San Diego native, I want to apologize to you all about the weather. Like 2 days ago, it was glorious, so this is very odd for us. So let's kick things off by talking about, why you think there is a presumed divide between NP and MDs, and then also, too, maybe for anyone who's not sure, kind of maybe briefly explaining what that divide is.
Just going to hand it off to me, huh, right? So I think this is an issue not only in DPC, but across the country. It's very obvious that it's out there. And I think there's some competition part of it, but I also think it's a misunderstanding and a difference in how we're trained. And I'm not here to say that nurse practitioners are here to replace physicians. I work with physicians every day. I appreciate everything that they know. But I feel, especially in the DPC space, this is the place where nurse practitioners can help us with this movement, right? We saw a map yesterday with 2,100 clinics across the country. And then, I don't remember who said it yesterday, but only 6% of physicians matched with family medicine this year. So if we want to make DPC the best thing that's ever hit healthcare in this country, we all have to do it together, because without it, we're just going to remain small. And so I'm here to tell you, I do not think any new grad nurse practitioner should start any practice of any kind. It's a terrible idea. They need that experience first, right? I opened my DPC after having 10 years of experience. I've been doing this for almost 15 years now. And I still ask questions, and I ask those questions of my fellow physician friends. I have the phone numbers of cardiologists, neurologists, urologists, general surgeons, all these people in my phone, because that's what healthcare is all about. If you find a healthcare provider who thinks that they know everything, you should run out the door right now. And so I think that's the beauty of DPC, is that we have the time to do the research for our patients, and we have the ability to talk to our fellow physician friends who can help us through maybe what we didn't learn in our training, right?
Yeah. I really like what you just said about working together too. And one of the prior panels too, talking about being brave and being vulnerable, right? I mean, that's one of the key things I'm noticing on this discussion.
Yeah, I appreciate all that sentiment. I know there's a lot of non-clinicians in the room here. You know, there's a lot of business people and software people. So I'm not sure how familiar the audience is with these topics. So I'll try to be a little bit more direct, because some people are like, what are we talking about here? You know, I mean, and the truth is some patients barely know the difference between physicians and nurse practitioners, and we hear this all the time when physicians get a little upset when people get confused about our training or our background or education, where a patient might call a nurse practitioner a doctor. And maybe there are some circumstances now based on our educational system where they have a doctorate. So physicians, and this is not unique to DPC, can get pretty upset, to be candid, about this topic. And I'm sure most nurse practitioners have experienced this. I know you have. But I think the public is like, they have no idea of what this is even about.
I agree.
And so, again, not unique to DPC, but basically it's a question of what is the appropriate role for this clinical training, right? And so, a physician and the amount of education and training we have versus a nurse practitioner versus an RN versus an LPN versus a pharmacist versus a physical therapist, respiratory tech. So these all these different degrees in education kind of give us a opportunity to be able to care for people in all these different ways. But ultimately it comes down to somewhat licensure, right? So every state, this is not unique to DPC, says this is the bar that we allow people to practice medicine. And so this big debate that we're having in our country, much larger than DPC, is about this topic, and what is the role of a nurse practitioner versus a physician versus another clinician is very contentious. And so, this obviously has played out in DPC as well. As a primary care physician, I think a lot of physicians feel historically we've been undervalued. Our practice, our ability to practice at the highest level has been minimized by a system that undervalues us. And we've just now discovered this thing. Some of us are old, like me, and been doing it 12 years. But physicians have finally kind of created this, ability or opportunity to practice as a true primary care physician. We've talked about that on stage. And so I think physicians, our concern is we want everyone who's in a DPC practice to be able to do that. And there are physicians who feel like nurse practitioners don't have the training or experience to be able to do that on whole. So that's really what we're talking about here, just to kind of state the elephant in the room.
Yeah, well, and also too, when you look at, our healthcare clinicians across the board being burnt out, right? And so to your point about being undervalued, especially when we look at COVID and, what that did to our system. Your thoughts?
So I talk about this a lot. I've been on stage on at least 3 different occasions at DPC conferences talking about the scope of practice that a DPC physician has. So what's so different about what we do is what Monica already said, which is we have the time to actually perform the tasks up to our level of training, which is significant. So we're doing surgical things, we're doing a lot of stuff that minimizes the need for referrals. So if I have a patient that comes in with something complicated, I have the time to figure out what it is and get them taken care of without sending them anywhere else for additional help. They don't have to see a specialist for whatever. But the night before the HINT Summit last year, before I came to talk last year, the night before I had a 7-year-old girl had a nasty both bone fracture of her forearm. I mean, it was brutal, and we got her taken care of in my office at no cost to her family whatsoever, beyond their monthly fee. Saved her $20,000 or whatever like that. That kind of stuff at my old office, even all the family doctors in my old, they wouldn't have done that. Wow. They would have splintered her up and sent her to ortho or something. We can do that. Mm-hmm. And so I have been outspoken about the need for all family physicians in DPC to act like family physicians, do all the stuff that you were trained to do in residency, and I'll get right in your face and tell you that you should if you're not. And not just because I think it's the best for the movement, but it's the best for your business. Your value proposition is, what do your patients get in exchange for their money? And if what they get is a whole bunch of referrals to really expensive doctors still inside the system, you really haven't done anything for them. And so it's just I think it's honestly getting to a point to where I would not be surprised if at some point we redefine the standard. Sorry, man, my voice is going. We actually get to the point to where we redefine the standard of care for family medicine and direct primary care and family medicine inside the system. That sucks, and it shouldn't be that way, but I think it's coming because we can do so much more for people. Well, that's my point. Then if you're going to do that to where you're really functioning at that high of a level, you need to have a huge amount of training. And if you're just going to be referring things because you don't even have the training for it, or you can't even, like Ryan said, you can't even get the licensure for it in your state, then you've affected the value proposition of at least your DPC. And if you've affected the value proposition of your DPC, then it makes all of DPC look bad.
That's a great point.
Yeah, thanks, Vance. And it does come down, you guys, physicians have extensive training. Myself, I come from the emergency medicine world, and so my training as a nurse practitioner sure was academic. And then, of course, when I went and did an emergency medicine residency with my chief medical director at my hospital, we learned a lot more other things. But I think it boils down for nurse practitioners, it's so important for us to know what we don't know. And what I really love about direct primary care is the transparency. And that's transparency not only in price, but that's transparency in service. And then the consumer should have a choice. I mean, if we're getting rid of the middleman, so to speak, right? And we're offering a new way of providing health care, part of that is giving the consumers choice. At the same time, it has to be safe choice, right? We got to provide high quality, safe care. And so as a nurse practitioner, I need to be very specific about what my services can and cannot be. For example, I don't do excisions, but to do an IND, I can do that, right? And then when it comes down to the specialty care, like you're talking about referrals, and I think there's plenty of literature out there that says there's a lot of referrals that come from advanced practice providers and those kind of things, and that's what we're trying to help eliminate. It's building our network. Like Monica said, on my phone, I have a general surgeon, I have a cardiologist, I have a urologist, I have the specialists there that I work with directly who provide cost-effective care for my patient panel. And my patients are happy. Matter of fact, my patients are so happy that they've told people in other cities, and DPC is expanding out there. And so I'm represented in 37 different cities around my area.
So interesting. So first off, I'm going to admit to you guys that I do not have a primary physician, and I have not for like 15 years.
Shame on you.
Now my son, of course, does, right? And I work in healthcare. Like, how embarrassing is that? So every time I go, they're like, I have to go through my whole litany of things again, right? And you start from scratch. The other interesting thing I picked up on right there, too, is you saying that knowing what you don't know. And I think that's honestly true for any industry that you work in. And again, going back to having that bravery and vulnerability to admit when you're outside of your comfort zone, right? And I think that goes pretty much for all of us in the room. The next point I wanted to ask you guys is in regards to and you kind of touched on this a bit, but how can we best serve the consumer here? That's so important to this conversation.
Sure, and so I want to touch a bit on Vance, because he's exactly right. To be a DPC provider, you cannot be mediocre, right? You have to show that value. And Vance shows that value by setting bones in his office. That's amazing. I'm not doing that. I worked for an orthopedic surgeon and set bones for 5 years, but I'm not doing it in my office. I don't have an x-ray machine, right? I know how, I did it, but that's not something I offer my patients. I do offer my patients joint injections and ingrown toenail removals. But I will tell you, I think the biggest value that DPC provides is the care, the relationship, the convenience. That's why people choose to come to my office. If I can reset their bone, that's awesome. We deal with minor fractures. I will not reset anything. I will send them to you for that, Vance. But you're right, it's knowing where your limits are, right? Like, I know where I'm not trained and where I am. And so, is it true that a physician could have a larger scope of practice? Absolutely, for sure. But that's all based off of your training. I am fellowship trained in venous and lymphatic medicine. Many people don't even know what that means, right?
I don't. What does that mean?
So that's a value that I bring that maybe a physician doesn't. And I will tell you, I doubt 100% of physicians in DPCs do joint injections, but I worked for an orthopedic surgeon for 5 years, and so I do. And I think this is the beauty of the free market of DPC, is that our patients choose to come to us. My office is only nurse practitioners. It's all over my website. You will not see the word medicine nor the word word doctor anywhere on my website. I do have a supervising physician because the state of Texas says I have to, and we follow all of their rules. But I think ultimately the value of DPC is in those relationships. And yes, I think you have to have an amazing scope of practice to prove that value, but I don't necessarily think that that is tied to the credentials after your name. I think that has a lot to do with who you are as a human being and being an exceptional provider.
I think you used the term badass when we were on our little call.
Yeah.
Aww.
Yeah, I mean, I would say that, yeah, you're on the conference call, you said you have to be badass to do DPC, and I think that's true. I don't think physicians who are concerned about, the role of nurse practitioners, there are some that are just so vehemently opposed to nurse practitioners at every, just saying the word makes them have a seizure. But I don't think the vast majority are concerned, would say, including myself, would say that nurse practitioners aren't capable of being badass. I employ a nurse practitioner, Vance does, and so there are many badass nurse practitioners. I think where the concern amongst physicians is that there are a lot of nurse practitioners, and just based upon the hours here, for perspective here, to talk numbers. So a physician, by the time they get through medical school and residency, if they're a family medicine doctor, you have between 10 and 15,000 hours, clinical hours, hands-on patient experience with, at least up until the pandemic, 99% of that was in person. Whereas nurse practitioners, depending on the state and their degree, have between 500 and 1,000 hours of clinical experience. And so the scope and scale, or the threshold of what is required to do that, is just radically different. And I think that's where physicians are concerned, is that your advice is spot on, and I hope most nurse practitioners would understand that. But the reality is they don't have to, right? Like a nurse practitioner can come out directly out of NP school and start a practice of any type, DPC or otherwise. And some of those programs are online only, where like 100% of their clinical training is online.
Mm-hmm.
That's...
They have to do it in person.
And they have 100% acceptance rate.
Yeah. Well, I think there are some programs that are real close to 100% online, like real close.
Actual clinical rotations have to be in the office, even through COVID.
Yeah. Yeah. But there is a much lower standard, and so not everyone's going to take the advice of someone like you who's spot on. And so I think our concern is that nurse practitioners with that number of hours of training could start a DPC practice without any supervision from a physician, and we're concerned about that because we don't want DPC to get a black eye by any bad experience of a person, or even larger than that. That's not unique to nurse practitioners. We've had DPC practices do things that I thought were very unscrupulous, run by a physician. So that's not a unique issue. But I think that's really what it boils down to, is like, what is the minimum standard? And this is a much larger issue than just DPC. But
Yeah, and I'm guessing that comes down to the states, correct?
yeah, and ultimately this is a state licensure issue,
Yeah.
which DPC is a tiny, tiny fish in a big ocean, and we have no influence over those discussions. But when physicians are concerned, that's really what it's about, is what is the threshold, what is the minimum threshold where a person should be able to practice medicine of some sort.
Okay.
Yeah, thanks, Ryan. I was on faculty for University of Central Florida for 7 years in the grad program, and I had some of the same concerns, by the way. I mean, I started in healthcare in 1989 as a flight medic, flew surgeon, rescue, medevac, and kind of worked every job all the way up into where I'm at now. And when I got to nurse practitioner school, to see someone who was able to get into nurse practitioner school that's been an RN for 1 year was kind of scary, And of course, then they come out, and then without the DPC model, right? Without that, just going and working at a hospital. Nurses that work in hospitals, they don't often work at the physician room. There's not a lot of RNs out in primary care, right? They're in the hospital, and hospital care and primary care are two very, very different things. Mm-hmm. First of all, you don't have the safety net, right? And so state of Florida recently passed autonomous practice. I could care less, it didn't matter to me. I have autonomous practice. I have a collaborating physician. Why? Because it's good business, right? It's smart business, and more importantly, it's good for my patients.
Absolutely.
For me to always have that person to ask that one more question. Just like we tell our patients, right? We give them enough time for that one more question. By having that 1 hour time, I have that time to call my collaborator and say, hey, Dave, I got this interesting case. What do you think?
Yeah.
So our staff, I have 2 nurse practitioners that share an office with me, literally this close. Like we literally, our desks touch each other in my office, and they're brilliant, both of them. And one of my first partner is a nurse practitioner who's a huge chunk of his practice prior to coming to work for me was in electrophysiology. He ran a huge electrophysiology lab, and that guy knows more. I mean, he knows more about electrophysiology than I'll ever know. And we recognize where our strengths are. All of us are like that. And those guys hit me up with tough cases or questions several times a day. And so does my staff at the other office. We keep a Slack channel open basically 24 hours a day, and they're always hitting me up with, hey, what would you do in this situation? What would you do with that situation? And I go up to their office often as well and do procedures or help them out with tough cases. I can tell you that all 4 of them are great. All 4 of them had a ton of experience, just like you guys. And they rely on me a lot. And all 4 of them are like, man, I would never, because of the scope of our practice and the breadth of what we do, none of the 4 of them, I asked them when we started talking, I'm like, would you guys, if you guys like somebody just gave you $1 million and you could build a DPC clinic across the street and just straight up compete with me, would you do it? And they're all like, oh, heck no. Like they don't want that sort of whatever responsibility or whatever. And they just don't feel like, again, they come back to the training thing. But again, that's because they all know what they don't know, which is the main issue I think we're talking about. I got a phone call not long ago from a nurse practitioner student who was in an online class. 100% of her classes had been online. And she was looking for a site to do her clinicals. And she's like, I only need 50 hours. I'll just come for like a couple of hours, every week for a year. And then I'll basically be a doctor. And I was like, you're going to kill somebody. And so, I don't know, that's the issue. It's not, I don't know, the training is changing and it's not created equal. And I think it's important. And honestly, I think it's exactly the same for doctors. I mean, especially since the pandemic, I'm seeing medical students who, my daughter is a freshman in high school. I've had her stitch up several of my patients. She wants to be my partner someday.
Aww.
I got her a suture kit thing, and she's rubber deal, and she's been practicing. She does better suturing than my last 4th year medical student did. She's a freshman in high school. She's good, man. This is my point. Like, even since the last several years, medical students aren't what they used to be. Their anatomy instruction is weak. Their surgical instruction is weak. And I don't know why that is, but we can't keep just like making training, I guess the right way to say it is watered down. And it doesn't matter who it is. And that's happening across the board here.
So what I'm hearing you say, Vance, is that we need amazing mentors, right? Whether it's in school or out of school, we need all the badass providers, PAs, NPs, MDs, DOs, the best of this entire country to become DPC providers. And so I think that was part of my whole reason for talking to Zach about having this discussion is there are very few nurse practitioners and PAs in this room comparatively to physicians. But if we could get more of them in this room so they could hear this conversation of, oh, you have 3 years of experience? Okay, you can do DPC as long as it's beside somebody who has a crap ton of experience and can teach you how to suture better than the other. And so I think that's, from my standpoint, that's the whole purpose of having this discussion is, yes, there is a divide. I am not a physician. I did not go to medical school. But I'm pretty good at what I do most days. And then when I don't know what I need to do, that's when I have Ryan or Vance or the mentors in this room to help us build DPC to be the most badass healthcare system in this country. And that's the only way we're gonna do it, is if we do it together. So if we could get Vance to mentor all of my 8-year-old right there, he'll come, right? It's all about having the best mentors. What got all of us to be successful is the mentors that got us here. And so whether that's a physician, an NP with 15 years of experience, that's what we need, is the best mentors and the best providers in the DPC space.
And I would just add to that, from what I'm hearing in this conversation, again, the shortages of physicians, when we look at the future, it's terrifying. We're losing great healthcare workers every single day. And, some of the statistics are horrifying. So when I hear about this, I'm excited because I'm like, yes, we need more great, badass healthcare workers to want to come, right? And the way we're going to get them to want to come is when we have things that make it easier. We make it easier for the patients. We have better technologies, which is probably why you have so many technologists in the room too, right? All right, so one more question, and then we're going to turn it over to some Q&A. So how can we move this dialogue forward? What are some practical recommendations that you could make for continuing and really improving this dialogue within DPC? Maybe start over here.
Thanks, I'll take that.
Okay.
And just one thing on Vance, I did 6 months with a dermatologist one time, and he goes, look, John, I know you're watching me doing all these fun things, because he was excising a bunch of stuff. And I'm like, yeah, it would be awesome. And he goes, but look, I can teach a monkey how to do that, but I can't teach a monkey how to think, right? And that kind of resonated with me, because doing skills, and nurses are great at doing skills in the hospital, and then they get a nurse practitioner, and they want to do these things. And it's not doing these things, it's thinking of what needs to happen, whether you need to do a thing or not, whatever that thing is. And so I really appreciate that. And good luck to your daughter, man. And if she wants to move to Florida, we'll be hiring, man.
Sounds like it.
From my perspective, how bringing everything together, it's, you guys have the physicians have great organizations, DPC Alliance, DPC Coalition, they have great access to new and great technologies that should be offered to all those patients that are seeking direct primary care. And right now, when you go on there, we don't have access to those resources because we're nurse practitioners or we're physician's assistants. And so it's not necessarily a seat at the table, but it's a seat at the resource, because that's where the information's at. We're seeking to be better care providers. We're seeking to provide excellent care. We're seeking to advance our knowledge in the different technologies and different resources that are out there. And that comes with being better together, and that comes with numbers. The better pricing comes with numbers. I remember when I got my first contract with LabCorp, it's not because I had a DPC practice, it's because I worked with a bunch of DPC practice and I got their group purchasing pricing, and that's what did it. And so if we keep the advanced practice providers on the outside of those resources, then we're actually limiting them from providing the care that they're actually capable of doing within their scope.
I don't know anything to add to that.
Okay. You ready?
We got 12 minutes. Let's do Q&A.
Oh, yeah, let's
I
do
can
it.
answer that, but I'm sure that Q&A will, yeah.
All right, sounds good. They're coming around with a microphone here.
So I take my family to a nurse practitioner who I think is probably the best primary care provider in the state of Arizona. And I trust her with my family's health. I also had a nurse practitioner student who rotated through our clinic, and we were agonizing about whether or not we should fail her because she was the most error-prone and confidently wrong person I've ever met in healthcare. And we didn't fail her. We probably should have. She opened up a clinic right down the street from us, a DPC clinic right down the street from us with no physician oversight. She doesn't need it. And so I'm just, I'm wondering what we do about the fact that the good providers, physician, nurse practitioner, or otherwise, are going to seek out and find mentors, are going to realize what they don't know and find the answers somewhere else. Are we supposed to be doing something to help the community or anybody else understand that not all health care providers are going to give them the same level of care?
Man, that's a tough one, because in your community, I think every doctor, every nurse practitioner knows providers in their community, DPC practices, hopefully not many of them, but in other practices that are not good providers. But it's a very delicate thing, right? Like we don't want to be seen as attacking someone because it seems like anti-competitive behavior, right? So we've definitely seen, even residents come to us, I'm sure Vance has too, that people want to start straight out, and some of them might be ready to do that and some of them may not be. But I think what we are really talking about is like patient safety, right? Like, I mean, but the challenge is how do we communicate that in our community without seeming like we're attacking that person, right? Because I promise you, if you said that publicly, in your community, that they probably wouldn't be very happy with you and say, oh, you're just mad because you're competing against me, right? So it's a very delicate thing, and I don't know a good way to do that in my community either. But that's right. Again, coming back to that like minimum threshold standard, and no matter where we set that standard, right? No matter where we set that floor of like independent practice or licensure, there's going to be some people who are not, under our view, capable of doing what they say they're going to do. I would say there's probably RNs. I have a badass RN. I've had several of them over the years, and I feel very comfortable with them advising people on lots of topics. And I still don't think they probably are in the position to be a medical provider on their own. But I think that's really what it boils down to, is we can't stop someone like that, right? Like in your state, there's nothing you can really do. You can hope that the mechanisms in place, if something bad happens, that they get reprimanded in some way. But I don't think we have power to do much.
I think, unfortunately, the free market's going to solve that. The sad thing about the free market solving that is bad things have to happen for the free market to move. So that the unprepared NP down the road is going to hurt somebody, and everyone's going to tell everybody else, and they're all going to come to your office. But now people are hurt. That's unfortunately what it's going to take. I don't personally see any other way this happens, because it's the government's not going to shut it down because they work for half, and I mean, the government lets people die. I mean, that's what soldiers do sometimes, right? They put a price on lives, and I think that unfortunately sometimes the price for more affordable health care is that some people are. It's sad, but that's the reality of it. And I just got to tell you, I've been teaching medical students, and for a long time I used to teach PA students and nurse practitioner students for 20 years, and I've only failed one student, and it was a nurse practitioner student who sounds, I think maybe it was the same person that you got. I feared for everyone's life, and I called the professor that was in charge of her program, and I was like, I got to fail one of your students, and she goes, it's so-and-so, right? And I was like, she knew who it was going to be. It was
and this is again not.
It was horrible.
That's not unique to nurse practitioners. Like we've seen physicians in our communities doing unscrupulous things and knew there was people being harmed, but we had no power to.
Yeah, what can you do?
You
have to let the free market do it.
Well, yeah. Eventually, someone gets in trouble for doing, things for whatever reasons. So that's not unique to nurse practitioners. But the mechanisms in place are, once you have that license legally to do it, there's nothing that's going to happen until bad stuff happens. That's just how the system is set up. But
yeah, you're right, Ryan. So legislation has a big part in this. We can't control that. We're not going to solve that up here, right? And so what do we do? And to the physician down there, he embraced, I'm going to bring a nurse practitioner in. I'm going to do part of her education and be part of the solution. And if she's part of the problem, we're going to make sure we do something there, right? Full transparency, I had a PhD professor wanted to become a nurse practitioner, and she had me for her clinical side for physical assessment and the didactic portion, and she didn't pass. I failed her. She was one of my faculty members, right? And I had 2 DMP students who didn't pass. I take what I do extremely seriously. It took me a long road to get here. I left healthcare for 10 years and got into technology because the system was broke in a long time ago. And I found my way back because I think one of the physicians said earlier, this is my purpose. My purpose is to love on people. My purpose is to encourage people. My purpose is to empower people. And I think the best way to do that is to have a healthy community. And I think as practitioners, maybe the solution is to embrace that academic people and teach them the right way so they don't learn the wrong way.
Yeah. All right, another question?
I just have a quick question. I'm an APRN in Montana. I own a clinic there. Again, similar to Dr. Johnson there. We don't have a physician oversight. But I agree with all the things that you're saying as far as, and I think nurse practitioners need to be, more educated and probably in a residency of their own. And I think that's how some of us survive, is by putting ourselves in the position to be in that residency. I was under a physician for a couple of years before I thought I was really ready to go. But again, with Dr. Lassey, which I think is the greatest thing that I've heard today, but in this is that, and what Dr. Johnson and I have discussed quite a bit is basically team-based care. And I really feel that team-based care with an interdisciplinary group is very valuable. We practice the nursing model, which again is very much different than the medical model, which is very different than the osteopathic model. We all have our own place in there, I feel, and often I do feel that we should be working more together than separately. And I think that's something we need to understand. This is no longer who's who on top, but who's best. And I just want to know if this is something that the panel thinks that maybe a team-based approach is something that you value. Is it something that you institute? Is it something that you grow with your students as well, to make practice more, I guess, better for our patients?
Well, absolutely. I mean, you can, like I said before, you almost can specialize. So my PA up at my North clinic, she knows like all of the sorcery and magic of female hormones that I don't know. I didn't go to Hogwarts or whatever. And so she handles all that. And Daniel, my partner right next 5 feet away from me, handles all the electrophysiology. But this is the point of the team. We're all together, so if one of our patients has a nasty fracture that needs to be set, or a complicated surgical repair of a trauma that I can deal with, we can keep them out of the ER. But it only works if we're all on the same team and under the same roof. And so from the scientific perspective, we should too. But you got to also think of it from your business perspective, and from all of us, it's all value proposition. So, like, I don't know what your PM is, Monica. Can you give me an average PM at your office?
85.
85. So mine's 60. And for 60, they also get the set fractures, the trauma repair, all of that stuff, because we're all together. So my value proposition is huge. And so that's why I think everybody should come up with a way to make it like a team, because everybody adds the stuff together for the same price. So the business model is damaged if you're like, oh man, it'd be cool if I had this thing to add. So like right now, for instance, I'm in the middle of a negotiation with a physical therapist to add him on, so that we'll be able to include physical therapy with our membership potentially, or whatever. We'll come up with a way to make it, but no matter how it works, PT is going to be way cheaper. And so the teamwork part's not just so that you don't feel like, am I ready, or can I handle this, or whatever, but it's also now we've added all of these, the skills of all the different people on the team to the same menu for the same price. So the value proposition is much bigger if you're not out there trying to do it yourself and saying, well, I've got a collaborating physician 400 miles away. Well, the collaborating physician can't set a fracture for you on the phone. You see what I'm saying?
Yeah, and I mean, that's what we do with our team as well, right? So I'm the fracture girl that deals with the injuries. I do the suturing. If there's a scalpel to be used, I'm in. But that's because I've done that training. And then I have my lead NP is amazing when it comes to autoimmune disorders, because she lives with 3 of them. She's also what we call our crunchy provider, because she knows all the supplements of the world for people that want to avoid the medications, right? So all 5 of my NPs have their strengths, and I think this is exactly what healthcare is, right? You have the orthopedic surgeon who's going to replace the knee. You have the neurosurgeon who's going to do the brain surgery. So I think it's always in healthcare better to have a team, because everyone's experience is going to add to that value, whether it's $60 a month or $85 a month. If you come to Austin, you're not getting it for 60, I promise you. But that's really where the value comes, and I think that can be added from physicians and NPs and PAs. It's all based off their experience and their expertise.
Yeah, well, and I would just agree. I think, overall in society, we're all better when we come at things together, right? We're stronger together than apart. Well, thank you guys so much. I've learned a ton about this topic, and I hope everyone has as well. And I know we're between you guys and lunch, so I think we should run.